and he serially biopsied their kidneys. After about a year, he noticed that the patients that had received these pancreas transplants, most of them, their nephropathy, their kidney disease was gone. So once you go a period of time with euglycemia, the kidney disease can actually disappear. Now, that doesn't happen for everyone. It depends where you are in your kidney dysfunction. But this was a landmark paper by Dr. Maurer in 1999. Quality of life. Now, this is definitely one of the things that really supports this operation. Is, you know, I've had patients that I've brought in and they've undergone pancreas transplants or pancreas and kidney transplants, and they may have even lost their grafts after some period of time. They may even have had complications because, you know, this is a big operation. I'm going to tell you, it's no walk in the park. However, their quality of life assessment is just off the charts different than where they were before. And most of them, even if they've had complications, tell me, you know, I would do it all over again, or I want to do it all over again, and, you know, we will retransplant patients. So quality of life is usually much, much better after the operation. Not all patients are going to be candidates, however. You know, it never fails. I go out, I talk to people, and they want to sign up, but there are contraindications. Although we want to help as many patients as possible, there are some people that are not going to be good surgical candidates. Diabetes affects you know, when you have diabetes, every organ in your body, every vessel in your body is affected. And there are degrees of how much it's going to be affected, and not everyone's affected in the same way, but it is a systemic disease. And because of that, some patients are not going to be candidates for transplantation for that reason. However, I'm willing to entertain the thought with almost any patient because I understand what the other side is. So I already talked about the islet transplantation and the challenges. Going back to the case report, we discussed the promise of islet transplantation, but that the therapy remains experimental. We discussed isolated pancreas transplant, and I went over all of the possible risk for her, and she decided to continue the workup for transplant. I will tell you, we eventually did transplant her about 6 months after I originally met her, and she did well and continues to do quite well today, and it's you know, not having to take any insulin. So she did opt to have a pancreas transplant. At this point in the talk, I'm going to cover briefly the other thing that I said I wanted to discuss because it relates well to what we're trying to accomplish. And this is the idea of disparities. And in this disparity that exists, I'm going to concentrate on minorities, but the disparity also exists for everyone with diabetes in the sense of getting kidney and pancreas transplants. So the problem with African Americans is that African Americans develop more kidney disease than anybody in this country. And they make up only 12% of the population, but they make up more than a third of the people that have end-stage renal disease, which means that they're at the point of needing a kidney transplant. This is a problem because it means that they have to sit on the waiting list longer, and the outcomes are not good. The best option is going to be living donation, but again, there are a lot of obstacles to people getting living donor kidney transplants. And a big part of what I try to do is get more living donors from the community, from the African American community, for kidney transplant. But I will tell you, the other big problem is, you know, for example, in this area, the Washington, D.C. metropolitan area has the highest incidence of kidney disease in the country, #1. And one of the reasons is it has the highest incidence of diabetes with renal disease. So remember the slide I showed earlier, diabetes has now become the #1 reason that people have kidney disease. Diabetes and kidney disease is particularly problematic because the survival is very poor once you're on dialysis. So in an area like DC, a large minority community, lots of people having diabetes, lots of people having kidney disease, the death rate, premature death rate is going to be much, much higher. So what we need to do is we need to address it by trying to get these patients transplanted as soon as possible. my whole argument is one of the things that should be done more readily for everybody, but particularly for minorities, is that they should be receiving kidney pancreas transplants rather than even just kidney transplants, because there are different lists, and diabetics do particularly poorly waiting even for isolated kidney transplants. So again, outcomes are not as good, on and on. I talked about the fact that there are racial disparities or ethnic disparities. Hispanics, African Americans, Native Americans, all of these groups have much higher incidence of end-stage renal disease. So even if you correct for the things that cause renal disease, like diabetes, hypertension, and whatnot, these groups still have very, very high instances of kidney disease. In other words, you take a middle-aged white gentleman and you give him diabetes and hypertension, those are significant risk factors for developing kidney disease. However, you take an African American with the same disease process, and that African American is 5 times more likely to develop kidney disease. So it's the kidney disease that is the killer. And people with diabetes, once they're on dialysis, they have a less than 10% chance of being alive 4 years. 4 years. So once you get to the point of being on dialysis, the clock starts ticking. And the idea is you need to get transplanted as soon as possible because of the high mortality. And that's why living donation becomes so important in that group. Because, again, for instance, in the DC metropolitan area, if you're waiting for a kidney transplant, you're going to wait. It differs depending on your race or ethnicity. Caucasians have to wait approximately 3 to 3.5 years for a kidney transplant. Minority patients, like African Americans, have to wait about 5.5 years. And it's because of the way we do the matching. You match up better with people that are from your same area of the world. So most Caucasians in this country have Northern European ancestry. Most people with black or brown skin have West African ancestry. So the way we match up kidneys, you're going to match up better with the people that donate more. You're going to get a transplant quicker. Well, I just told you that if you're diabetic and you're sitting on dialysis, only about 10% of you are going to be alive in 4 years. So you look at African Americans that are going to have to wait 5 to 6 years to get a kidney transplant. They're not going to survive if they're waiting for a kidney transplant. And that's the whole process of why I did this study that I'm going to talk about. So again, I kind of went over all this. And this is true even in the pediatric population. So, you know, I do all the pediatric transplants over at Children's Hospital, but the same issues occurred there as well. So I don't want to go, here we go. So this is what I was alluding to. If you look at this green line here, this is survival. So the higher the line, the better, okay? So this is all patients by modality. So the green line is survival in patients that receive transplants, and that's good. That means, you know, so going out 5 years, patients that receive transplant, about 80% of them are alive in 5 years. If you look at the blue line, that's patients on any type of dialysis, and the other lines are peritoneal dialysis versus hemodialysis. In other words, these patients are dying, and by 5 years, less than 40% of them are alive. Now, if you go by diagnosis, the blue line are diabetic patients. So this is hemodialysis. Once you're on hemodialysis, if you're diabetic and you go out here to 5 years, you're down to about 25% of patients are alive. Now, most of those patients are type 2 diabetics. Okay, and if you look at type 1 diabetics, it's even worse. So, and if you start to break down by age, it worsens. And the same thing happens to peritoneal dialysis. So the point is, diabetics, once they develop end-stage renal disease, they die very quickly. And what they need to have happen is to move from here to here, and that's by transplantation. Yes, ma'am. What was the what? Hypertension. Yeah, those are hypertension patients. Remember, the two most common reasons to get kidney disease is hypertension and diabetes. And if you look here, this is called GN patients do the best. That's glomerulonephropathy. And what that is really showing is it's the difference between having a systemic disease and a kidney problem. People that have kidney problems actually are the patients that have the best survival. So if you were born with some kind of congenital problem with your kidney, or you developed a kidney-specific issue, you actually do better on dialysis, and you're going to do great with transplant. The problem with things like diabetes, hypertension, these are systemic diseases. These people have heart disease, they have vascular disease. Like I said earlier, every organ, every vessel in your body is diseased to a certain extent when you have diabetes and hypertension. And that's why when you put on top of that a toxin like cigarette smoke, you're accelerating those problems. So this is the paper that I wrote. It's called, Impact of Medicare Coverage on Disparities in Access to Simultaneous Kidney and Pancreas Transplantation. Basically, what I looked at was Medicare. We have all this discussion about universal health care. Well, if you have kidney disease in this country, you really have universal health care. So once you get kidney disease, the government covers. And that goes back to the 60s, because there was a very influential politician whose daughter had kidney disease, and he realized it was very expensive to keep her alive if he had to pay for it. So so the government started paying for kidney dialysis back then, when it was very rare to be able to receive dialysis, and it's gone on. So now the government actually pays for dialysis, which is great, because dialysis does extend the lives of people. There are many people that are alive today that would not be if they were not receiving peritoneal dialysis or hemodialysis. Before the 1960s, once you developed kidney disease, you fell asleep, you became uremic, and you died. That was it. There was no treatment. And now we keep alive millions of people because of things like dialysis. Well, universal health care means that all of these patients get their dialysis paid for by the government, and that can be very expensive. It's over $80,000 per year for the government to pay for each individual to get hemodialysis or even peritoneal dialysis. So it's very, very expensive, but it keeps people alive. Well, the government will also help pay for things like transplant, and transplant actually gives them a cost savings, because although the original operation and all of that goes into that can be very expensive, about $200,000. If you have a transplant that lasts about 3 years, you start to save the government money, and they not only get the savings of not having to pay for you to be on dialysis, but they also reap the savings of turning these people back into citizens again. They can now become parts of society and work and whatnot. Most patients that are on dialysis cannot do that. So it is beneficial to the government to get people transplanted. And it's for that reason that the government has started to pay for transplant. And this started with kidney transplantation, and just recently it started with pancreas transplantation since around the year 2000. What I wanted to do, I wanted to go back and look at what was the difference before the government was helping to pay for transplant and now after the government has paid for transplant. I'm talking about pancreas transplants. And again, the background of the study was that there have been previous studies that have shown that people that have kidney disease, once they get universal health care, their health care coverage and their health actually improves, although they have a problem that actually decreases their health. In other words, although now they have kidney disease, they're on dialysis, and like I told you, that's no walk in the park, they actually get everything else handled that couldn't get handled before because they have government insurance. So the person the poor person that has kidney disease, all of a sudden can now get their heart taken care of if they need a heart bypass, or they can get their lower extremity bypass done because they have Medicare coverage now. And that makes a big difference to their overall health. So I wanted to see if the same thing happened with pancreas transplantation. And here's what the 3 basic questions I wanted to answer. Has the previously documented racial disparity disappeared? In other words, we knew that by your race, people that were African Americans are much less likely to get pancreas transplantation.